Hello, good evening. Good evening, everyone. Thank you for coming. I will start the talk about Oxford UKA step by step. Okay. So in the last week, I told about the importance of the peeling of the peel luggage. So using the two fingers, it must be inserted. It will lightly using two fingers, but never push force very strongly. Otherwise, you can cause the overtension or unnecessary elongation of the MCL that can cause the elongation of the MCL that can cause the loosening of a medial side. So in addition to the peeling of the peeler gauge, the feeling of the bugger stress is very important. So to feel the proper tension of the bugger stress, you should feel the bugger stress in the patient before the surgery. Uh, you can hold the patient legs and apply the bugger stress. You can feel the normal length of the MCL. Then, this is the good tension for applying the bulgar stress in this procedure. Anyway, it is quite important to apply the proper bulgar stress. If bulgar stress is insufficient, you can cause the very residual vellus after the operation. So if you see the vellus alignment, you will be very disappointing. So apply the proper. But the bulgar stress is too strong. You can cause the overcorrection that can cause the elongation of MCL. In the same time, the lateral side cartilage wear, so-called lateral OA progression. So, so please show the video in the flexion. You must be this pyramid should be inserted using the two fingers. And ideally change to the 1 millimeter thicker pyramid. You cannot insert into the joint gap. So the size 3 is very smooth and size 4 is very tight. It is ideal. You should choose 3. In extension, it is more difficult. Upright bulgar stress. I recommend you to apply bulgar stress by yourself, and you should insert the filler gauge and change the 1 millimeter thicker one. It is too tight, so then you decide the extension gap and the flexion gap. Then flexion gap minus extension gap should be the spigot side you should use. So implant, the posterior surface of the implant should be aligned to the same level as the posterior cartilage surface. This is the ideal. Then, this is the concept of spigot, the distal femoral mirroring. So this is a distal femoral adjustment. Uh, so using the mirror, you can change uh, the distal level of the femur, middle femur. So using the spigot, the first three you should size 0 and mirror. So this mill is stopped by the color of this spigot. So then the previous case, friction gap was 3, and the extension gap was 1. So you should use the side to spigot. Please have a look. This spigot is 2 millimeter thinner than the previous one. Then insert and mill. So mill goes 2 millimeter thicker than the previous one, size 0. So it is confusing. Maybe the beginner surgeon might be confused by the size selection of the size of spigot. But it's very simple. It's very clear. The size of the spigot directly shows uh, the depth of the milling, the amount of the bone millings. So size 0 is here, size 1 is here, size 2 is here, the size 3 is here. So the first 3 you made the mill, you use the mill using the 0 spigot, and then the difference between the friction gap and the extension gap is 2 millimeter. So it means you need 2 millimeter more additional cut from the distal end of the femur. So you should choose spigot. After the 2 spigot, meaning it is still 1 millimeter narrower in the extension gap than the friction gap. You need 1 millimeter more the milling. As a result, the bone cut thickness should be the same, because 2 millimeter cut is insufficient. It needs 1 millimeter more. You should use the 3. But some surgeon is misunderstand. If the first spigot you used first spigot and the 2 spigot, then you need to 1 millimeter more and change the 1 spigot. This is incorrect. You should use 3. 2 is uh, the insufficient. You need 1 more, so you should use 2 plus 1 equals 3 millimeter spigot should be used. So anyway, the base of this milling is standard of milling is this one. The surface after the 0 millimeter spigot. The spigot size indicates the thickness of bone cut from the level of the 0 spigot. Okay, then adjust the pressure gap and extension gap. If complete, this is another pitfall. Sorry. So in the manual show that you should evaluate the extension gap in the 20 degrees in flexion. But in fact, some patients have the smaller gap in the extension, full extension, than the 20 degrees in the flexion. So in other words, 0 degrees extension, full extension gap is wider than the 20 degrees in flexion. So I recommend to evaluate not only the 20 degrees in flexion, but also the full extension. So you should select the bigger one. If the 20 degree inflection gap is 3 millimeter and full extension gap is 4 millimeter, you should select the 4 millimeter. If the 20 degree is 3 and full extension is 20 degree flexion is 4 and full extension is 3, you should use the 4 in the 20 degree flexion. Then after the adjustment of the flexion and extension gap, you should fix the tibial tray on the tibial cutting surface using the long pin. At this time, I recommend to fix this tibial tray using the pull and push technique. It means the T-handle pull, it catch place on the posterior surface of the tibia and push the tibia tray posteriorly. Eventually, the posterior cortex and the lateral edge of the tibia tray should be in the same level. Keeping this position, the pin should be inserted. It is very important not only anteriorly, but also the laterally. Use the T handle. Push anteriorly and push laterally. It's very important. Otherwise, sometimes you will be disappointed. You will find some space between the lateral wall of the tibia tray and the lateral cutting surface. So to avoid this, you should push the tibia tray on the lateral cutting surface and pull the T-handle and flush the posterior surface on the tibia tray and the posterior cortex. Okay. Then after the fix on the tibia tray, so this pin, you should hold this pin by yourself. Then you can feel the movement of the tibia tray. If the tibia tray move posteriorly and anteriorly, you can feel this movement through this long pin. But if your pin is placed hold it by the assistant, you cannot feel the movement of this tibia trial because it is quite important to prevent the posterior cortex breakage during the keel slot preparation. So if this tibia tray move posteriorly during the saw cut, so that saw can damage the posterior cortex. So hold this tibia tray using the pull and push technique, and then hold the pin by yourself. It is quite important. So have a look. Insert the tibia tray and pull and push. Then assistant insert the pin. Then hold the pin by yourself in the left hand and use the tooth saw using your right hand. I call it the dolphin technique. Never push the disc saw posteriorly. Otherwise, sometimes you can damage the posterior cortex because this saw can slip posteriorly. So to prevent this, you lift up the saw and cut down. Then lift up and move slightly posteriorly and then push down. We call it the dolphin technique, like the movement of the dolphin. Again, please see again the dolphin technique and push downward and lift up, then down, up and down, up and down. Then you can feel that this tooth saw reach the posterior end of the slot through this pin. If the tooth saw reach the posterior end of this keel slot, you can feel the vibration through the pin. Then gently move forward. Then the to so reach to the anterior end of the keel slot. You can feel the vibration through this pin. So repeatedly going back and going forward, then you can feel the vibration in the posterior side, and you can feel the vibration anterior side. It is quite important. You should make the keel throat completely. If it is incomplete, the keel can break the tibia bone that can cause a fracture or during the tibial implantation. After the keel preparation, you should remove the bone dust from the gutter of the keel throat using this special teaser. Sorry, this way. Sometimes anterior edge bone cut is improper, so you should carefully remove the bone from the anterior edge of this keel throat. Then check the keel throat. This is a very good keel throat. And make sure there is still bone between the keel throat and the posterior cortex. Sometimes you might be disappointed due to the continuous keel throat from the this throat to the posterior cortex. Sometimes this keel throat can damage the posterior cortex. This implies an increasing risk of the postoperative fracture. So again, you should keep the pin by yourself and feel the movement of the tibia tray and the vibration and when the keel saw reaches to the anterior edge or posterior edge of the keel slot. It is quite important to prevent unnecessary breakage of the posterior cortex. Then insert the anti-impingement guide. At this time, never flex the knee. You should flex the knee in the 90 degrees flexion and pull down the leg to enlarge the bone gap. If you flex the knee deeply, this big slot can damage the posterior edge of the tibial cutting surface. You should avoid this. So again, in the 90 degree flexion and pull down. Then cut the anterior mill like this. Then through the slot using the chisel to cut the posterior osteophyte. Anterior mill that can remove the bone to avoid the impingement in the flexation of the knee and between the bone edge and the bearings. It is quite important. Uh, to to insert this, the knee is slightly extended, approximately 30 degrees in extension. But in this position, this reamer can damage the tibia cutting surface. So once you insert this reamer into the peg of the anti-impingement guide, you should slightly flex up approximately 60 degrees or 80 degrees, then make use the mill. Then insert this chisel through the throat and remove the osteophyte from the posterior edge of the medial femur of the condyle. Video insert this one in 19 degrees depression. Never flex the knee deeply at this procedure. Impact. Then extend and insert the meal, and then at the time this anterior edge of the tibia cutting surface can be damaged by this reamer. Then extend, insert, then slightly flex and drive the meal. Okay, then remove. Then insert this chisel and hammer. Use the hammer. Well, at this time, please have a look. I lifted up the condyle using the chisel. It is quite important. Otherwise, this blade of this chisel can slip over the osteophyte. To prevent this, you should insert the chisel through the slot, then lift up the condyle, and then hit the hammer. It is quite important. After, sorry, after the using the chisel and the remove of this anti-joint guide, you should use the chisel again and remove the posterior osteophyte complete. Then you can get the osteophyte here. Okay. Then this is the final trial. The inside the tibial trial that has the keel tibia tray trial, and the two peg femoral component. Then insert the trial bearing. So this is the insertion of the tibia tray, and insert and push and impact very, very gently. Otherwise, you can make the fracture. And this is the two peg component. It is slightly extended anteriorly. So because this component is implanted in 10 degrees in flexion, so we need the extent of the anterior side, extension side. Then insert and lift up test and spinning test. At this time, you should check the first looseness and the second in the spinning. To the loosening is expressed as the lift up height, lift up height. So like this, after the insertion of the bearing and lift up this bearing using the handle. If the anterior edge of this bearing is lifted up 2 or 3 millimeter, the gap is enough. But it is lifted up more than 4 or 5 millimeter, it applies the gap is too wide, gap is too large. If it is lifted up less than 2 millimeter, it implies it is too gap is too tight. Okay. Then check the bearing motion. Ideally, the keeping the space between the bearing and the lateral wall of the tibia tray is 1 millimeter, and keep the 1 millimeter space throughout the motion from the full extension to the full flexion. It is ideal, but it is quite difficult to achieve this. So sometimes this bearing hit the lateral wall, and sometimes the distance from the bearing and lateral wall is very wide, very separated. So both the hitting of the wall or separating can cause the dislocation of the bearings. So to make sure, I recommend to check the space between the bearing and lateral wall or the tibia tray before the keel preparation. So if you check the space between the bearing and the lateral wall at the time, if it too close, you can recut the vertical cut of the tibia to place the tibia tray more laterally, and the space between the bearing and lateral wall is too wide. You can move the slightly medially the tibia tray and fix, keeping this position, and make the keel slot, and the gap between the lateral wall and the lateral cutting surface, you can feed the cement or bone tip. So in this case, it is very ideal. So, but sometimes in the full extension, this bearing is separated from the lateral particle wall of the tibia tray. This implies the direction of the tibia cut is too external rotated. So external rotation can cause the separation in the flexion and the hitting in flexion, and in the same time it can cause the decreased clinical outcome and the sometimes subsidence. So you should avoid the external rotation cut. So this is the final check of the bearing movement in the extension and the flexion. You sometimes check the rotation, external rotation of the tibia and the internal rotation of the tibia. Flexion and extension. Okay, finished. Then later, uh, in the cementing, in the final implantation, and the final check. I will talk the next week. This is the end of my talk, this week's talk. Thank you for coming, and see you next week. If you have any question or some comment or suggestion, please send me an email or leave the comment on this site. Thank you. See you next week. Have a good night.
Hi, Professor.
Yeah.
Hi, can I ask, in the previous slide, I can see that the insert on extension, actually there's slight protrusion anteriorly. Is it fine?
Sorry. So previous one.
Insert.
Please wait. This one?
Yeah, it's this one. On the right-hand side,
Yeah.
over the medial side, there's some slight overhang. Is it fine? Because
That's fine. It completely no problem.
Okay.
Because it is unavoidable because of the design of the bearings.
Okay.
Okay. Yes, but sometimes the patient complies the uncomfort
Mm.
of the despairing, but there is no pain. The patient have no pain. This one.
Okay, because from my experience, for the femur and the tibia component, there's some discrepancy. Usually, the femur component would be larger than the tibia component in my patient group. So I always encounter such a scenario, but there's no spinning, so we just leave it alone. So I was just wondering if it's a common phenomenon.
Yes. Regarding to the overhanging of the bearing, it doesn't matter, but you should check the bone here, the medial edge of the bone cutting surface. Here, medial side, this sharp bone can cause the soft tissue impingement. I experienced one case. The patient has still pain and discomfort after the surgery, and then I removed the corner of bone here. Then the pain and discomfort disappeared afterward. So never mind the overhanging here, but you should carefully check the sharp bone here. Okay?
Okay, thank you. Thanks, Mike.
Professor,
Thank you.
may I ask
Yeah,
one more questions?
yeah,
This is Michael from Hong Kong. Because
yeah,
very occasionally we do encounter, let's say, we have a quite a good alignment of the femur and also tibia in the flexion. But
yeah.
somehow when we extend it, we see actually the insert is splitting a little bit. But so how much degree that you will tolerate for the splitting of the tibia component when it comes to the extension?
It's a quite a difficult question. I don't
Yeah.
have the true answer.
Okay.
Okay.
Because sometimes I just a little bit worry because what Thomas had mentioned is the anterior protruding of the insert.
Yeah,
Plus, if the same time when there's some rotation of the splitting of the insert, then I
yeah,
sometimes I
yeah,
will worry that the
yeah,
patient will feel some impingement when
yeah.
they have the extension.
Yes. Uh, I don't know. I have the true question. I have the true answer. I'm sorry, but
That's fine.
actually, you should avoid external rotation,
Right.
external rotated cut.
All right.
So if you cut external rotated in the extension, the bearing can separate from the lateral wall of the tibia tray. That can cause the spinning of the bearings.
Okay.
Okay,
Because
so
I watched the previous video that you mentioned. When you cut the tibia vertical cut, you try to point to the ASIS, isn't it?
yes, yes,
But sometimes it's very difficult inch off for you to judge because when the knee is fixed in position, then you try to point to the ASIS. It can be quite variable according to my experience.
yeah, yes. So I understand. Uh, but uh, it might be your answer. It might be your answer to achieve this. Anyway, the first three you should mark the top of the medial spine using the cut ray, then put on the saw blade
Yes.
on the top of the medial spine, and then aim to the ASIS.
Okay.
The good this is the technique to put on the rod from the ASIS and the center of the knee, and the assistant hold this rod, and then set the saw blade parallel to this rod.
All
But
right.
at the time, the major surgeon worry about the two internal rotation cut to
Yes.
aiming to the A size can damage the PCL.
Yeah.
Yes, to avoid the PCL damage, in the first step of this procedure, you should make the space between the medial lateral edge of the medial condyle and the PCL using the elevator.
Right.
So it is quite important. You can make the space and you can feel the space between the PCL and the lateral wall of the medial cortex by your hand. It is quite important. Otherwise, you can damage the PCL.
Right.
So it's quite risky to the ball cut aiming to the ASIs because of the tip of the saw directly toward to the PCL. So before this one before the title cut, you should make the space and feed the space using the elevator and then mark here and then aim to the A size. Previously, the of-course manual described that the title cut should be aimed to the femoral head center,
Yeah.
but it is too external rotated in most
Right.
cases. But there is no evidence the
Right.
ASIS is proper or not.
Mm.
But I believe that toward the ASIS is even better than the toward the femoral head center.
Right.
But my colleagues studied the relationship between the tibial rotation cutting angle and the clinical outcome and subsidence and overhanging and uh, and, I'm sorry, I forget many factors, but most factor is affected by the rotation and external rotation cause the bad outcome in the
Right.
clinical outcome and adaptation of the tibia tray and uh, stability of this tibia tray is worse in the implanted in the external rotation. You should avoid the external rotation. It can cause many bad things.
Right.
So you should aim to the ASIS. In other words, internal rotations as much as possible, as long as you do not damage the PCL. It is quite important.
Right. Okay.
Okay.
Thank you.
Is it your answer?
Yeah. Yes. Thank you.
Okay. Yeah. Okay. Anyway, if you have any other question, please send me your email. I will respond you later. Okay. Thank you for coming.
Thank you.
See you next week.
See you next week.
Goodbye.
Thank
Have a
you.
good
See you.
night.
Bye.
Thank you.